Now, welcome
Including
everyone
me.
to the Greening Healthcare OR Ventilation Best Practices webinar. The purpose of today's webinar is to go through the best practices that we have listed in our OR guide, which is available on greeninghc.com. We haven't looked at this project in a little while. It is an important area of conservation and emissions reduction. So we're revisiting it and we're planning to update the guide fairly soon. We're pleased to have Class 1 sponsor this project and join us here. They're the experts in anesthetic gas recovery, and it's going to be exciting to work with them on this. You'll hear from them in a bit. Let's just go through the agenda then. Let's get right into this. So first, we're just going to give the framework of the guide and the research that have been done to date. And then we're going to kick off two unoccupied setback retrofit case studies, one at North York General Hospital and one at the Alberta Children's Hospital. And then we're going to hear from Class 1 about the anesthetic gas recovery, as well as a panel discussion on basically the challenges and communications with working with OR systems, since they are kind of a highly sensitive area of the hospital, and it's sometimes difficult to get projects done. As always, you can ask questions using the Q&A at the bottom of the interface. And with that, I'll kick it off and pass it over to Ian Jarvis with Greening Healthcare.
Okay, Michael, thank you. And good morning, everybody in BC and Alberta. We've got kind of great geographic coverage today, and good afternoon to everyone in Ontario and points further east. As Michael said, this is picking up on the 2017 work that was done around operating room ventilation and best practices, and how could they be upgraded for both safety and energy efficiency and emissions reduction. And what's really changed since 2017 is just a large amount of practical experience of actually trying to make some of the ideas and the original guide work. So as Michael said, the intention is to upgrade that guide or update that guide sometime in the next several weeks. And as we go through this, we'll be looking for further information from a number of the hospitals that are on the call today. We've got just about all of our acute care members on the line today. Further information to kind of, if you like, illuminate and elaborate on the findings that were in there. As always, this is one of our single topic Greening Healthcare webinars. We're holding those on a fairly regular basis now. The sole purpose of the webinar is to help initiate action. So every acute care hospital on the line can either start planning towards retrofitting their operating room if they do not have airflow setback or upgraded controls right now. And those that already have setback, I think what we share will prompt you to go take a look and see how it's really working. Because so far we've yet, as we've dug into the actual operating conditions on systems with setback incorporated, we've yet to find them working the way that either the design intended to, or that the staff of the hospital thought they were. So it's a key area for obviously health and safety reasons, as well as energy efficiency reasons. And I think there's something here for everybody, but the goal is that coming out of this will be action. We're going to be conducting a couple of polls later in it to get some feedback from you on what you have and what issues get in the way, what things you would like us to tackle. But today should be the beginning of a conversation, an ongoing conversation around how do we actually move from the principles, the design principles, into taking action, delivering savings, and assuring ourselves that we have a safe operating system. So that's where we intend to go over the course of the day. Wanted to quickly review the design principles that are in the current version of the guide, because these don't change over time. CSA hasn't changed its mind about very much of this, and again, the big ideas are there. The energy costs we've updated in terms of what it costs to run these systems, but these principles stay the same. The panel discussion at the end, we want to get into much more nitty-gritty about how do you actually make this work. As I run through the principles of the guide. I've asked our Director of Engineering, Amandeep, to come along with me so we can kind of pose some questions in bigger detail. And to repeat Michael's invitation, if you have particular questions, please post them, and Michael will be reviewing them. And if there's something that fits into what we're trying to do today, we'll try to tackle them here. And if not, we will definitely follow up after the fact. The poll is just for the hospitals with operating rooms on the line. The invitation to ask questions is to everybody. You know, this we learn primarily by the questions that you ask us. So back to 2017. This was the original version of the guide. As I say, it's still posted on Greening Healthcare, greeninghc.com, and it will stay there until we replace it, and say we expect to do that in the next 4 to 6 weeks. The core in the center of that, and Amandeep, maybe you could tell us what is more critical on this. This essentially is what CSA requires, that we stay within that little purple, whatever that shape is it a rhombus or a trapezoid or something within that area? And I think, Amandeep, the critical thing is that upper limit in terms of relative humidity.
Yeah, I think so. Yeah, so basically, I mean, this chart is your psychometric chart that shows you the boundaries around where you could operate your operating rooms, but those boundaries are sort of more critical when you look at it from, so for example, in a winter period, you're looking at your RH, the minimum RH is 30%. For summer, the maximum RH is recommended by CSA 60%. So you still want to be within the boundary, but sometimes some of their requirements are dictated by your clinical staff. So just to understand how these came along is the key when you're talking to clinical folks, that this is the range that is recommended by the CSA, and this is how you, at least bare minimum, you have to maintain those requirements of the CSA.
Thanks. And in terms of experience since 2017, probably the two worst examples we had were when humidity got out of control in 2 different situations, and $1 million worth of sterile supplies were lost, stored within there. And you'll see also the addition from last time that the unoccupied air change rate raised to 9 air changes when we are storing, in particular, chemicals within the ORs. So, but this is basically the game: is we want systems that can keep us in that box as efficiently as possible, and that's what the whole guide aims to work towards. The unoccupied setback is, again, this is from the original guide. It's all about maintaining the proper pressure differentials between spaces. And when I kind of give a bit of an overview of the North York General retrofit, you'll see this challenges in practice that come out of trying to do some of these things. Relative pressurization is not easy to maintain, especially when doors are opening and closing, and sometimes because of openings between spaces. But knowing how much airflow is supplying, being able to control both the supply and the exhaust air, and be assured that we know what the quantities are, having airflow monitoring or regular testing so that we know what the volumes are when they're open and closed. And cleaning practices are engagement with the cleaning staff so that they're not taking actions like propping doors open that cause issues during unoccupied periods.
So just one addition to this, Ian. Basically, if you're a hospital, you might be in a sort of 3 different scenarios where you have the infrastructure to control the airflows, for example, where you have VAV boxes on supply and exhaust or return, or you could have eventually valves on those, or you could only have a scenario where you're not able to control the airflow. So you could be in 3 different scenarios, but the idea is you could still set the unoccupied mode, but it could be initially for at the system level, and eventually once you upgrade the system, then you can move on to controlling the individual operating rooms. So there are different options you can do with controlling the operating rooms or doing an unoccupied setbacks, depending upon what kind of infrastructure you have in your facility.
And the location and the sensitivity of the occupancy sensors, again, has shown up from a number of projects as being a key issue. This picture actually came from the original Sick Kids retrofit more than 15 years ago. It took them months to get that set up properly and not have it just cycling on and off and on and off and on and off all the time when anything kind of got in the way. So unoccupied setback is the core strategy for reducing energy use and operating costs. In terms of how much this costs, and because we predominantly Ontario and Alberta membership, we've got the metrics here for Toronto and Calgary. The reference air ventilation system that we ran through the guide was 25,000 CFM, which is bigger than rural hospitals and smaller than some of the giant hospitals you have, but it's a kind of reference point. In Alberta, for obvious reasons, the colder weather, the energy use and the emissions are higher, but the utility costs are significantly lower. But this we find helpful in terms of thinking about what is the magnitude of the savings potential. Many operating room systems are using well over $100,000 a year in utility costs for a single air handling unit. So these are big numbers. Again, in the guide, this is all there. What we were tracking through for the 4 hospitals that participated in the original research was what kind of systems they had. So here we've got glycol heat recovery, we've got thermal wheel heat recovery chiller, and so on, and with and without unoccupied setback. So the aim of this was to provide information by which designers and hospital staff could get a feel for what's the magnitude of savings by implementing these things. But to run 1 CFM per year through operating room ventilation configurations that are ranged across here is anything from $6 to $2 in Ontario. And what we're going to be beginning with you today with the polls for the hospitals on the line is beginning to understand what kind of systems do you have right now, because we would like to take future work in this area around the actual configurations that you're working with. So that poll is yet to come. Those are the numbers for Toronto. These are the equivalent numbers for Calgary. Again, higher energy use, lower utility costs, but still very significant. Again, a 25,000 CFM system. The basic system is going to be using $75,000, $100,000 a year. These are big numbers, and one of the best areas for retrofits to reduce energy use, energy costs, and greenhouse gas emissions if you don't have setback installed already. So as you work through this, with Greening Healthcare members, we've got this little nifty tool that we're happy to use with you. So as you start down this path, you or your engineers, we're happy to take a call and kind of plug the numbers in. You can see this is the 25,000 CFM reference system. It takes like 30 seconds to populate this with the characteristics of your particular hospital and what you plan to do, and the numbers pop out at the bottom as to what the preheat, cooling, reheat, fan, and humidification energy is. Then you can play your what ifs and get a pretty reliable estimation of what the savings potential is for the project you're looking at. Then, as we'll talk about later, you work your way through the costs. The other area that we developed in 2017 and that we will be talking to, again, all of our acute and ambulatory care hospital members is the importance of regular system testing to validate that the airflows are what we think they are, and to test them both in setback and normal mode, and then do the simple math as to how many air changes an hour do we see. The conclusions last time were of great interest and great use because all of the participating hospitals were handling too much air compared to code, and they were all able to make fairly simple reductions that delivered immediate savings. But regular system testing and the controls piece of that is the other really big deal that we have proper trend logging set up, that you can track the real performance. So you can see the actual use of the operating theaters. You can see what the fans are doing at those different levels, both in terms of percentage speed and kilowatts, and track the supply air temperatures, the space temperatures, the relative humidity levels, and be confident that they're doing what they should be, both in terms of health and safety and in terms of optimizing energy use, energy costs. The third area within the guide is around sensors and controls, and do we have within the operating rooms the temperature and humidity monitoring that we should have? Is our pressurization control effective? And if you, in each case here, it's what did we find in each of the 4 hospitals that we worked our way through. So this looks at controls and sensors within the operating rooms at the top and within the central systems at the bottom as to how are they actually running. And all of these measured factors have a significant impact on energy use and performance, and again, particularly as they relate to humidity levels, particularly during the summer. Once again, from a central system standpoint, knowing what the supply air temperatures are, you can see this was just immediately after a retrofit in one of the hospitals, and you can see the supply air temperature gets a bit out of control, starts cycling, and that's when you find that you don't necessarily have the control valve capability that you thought you had before. And again, the message coming out of this is always the attention to detail and to measurement and verification is a really big deal. And the best practices kind of flow out of this. So setting back airflows to each OR when it's unoccupied to the extent that the ductwork allows that, managing air change rates, managing recirculation when it's in effect there, which can achieve further savings and can do so safely if it's done properly. Confidence in airflow control, the monitoring control, what's installed, but also the set points. And again, the constant need for measurement and verification. These systems are not just set them and forget them. These systems absolutely need regular checkups. Within the guide right now, and we'll be updating this, is a checklist. And this is where we'd suggest that you begin and then reference the guide for where further to go. Part of the checklist around operational changes, and this is what the 4 hospitals had in place, and the other is around retrofit projects that you can put in place. So that listing is there. Again, we'll be updating this in the new version of the guide on practices.